A very good afternoon and welcome to our Breakout 4 session entitled Managing Older Adults with COVID-19 in Care Homes. I'm Kajal, a budding geriatrician from University Malaya Medical Centre, and it gives me a great pleasure to be moderating this session, which is indeed timely given the current ferocious pandemic we are in. Based on the population clock at this time, Malaysia's population stands at 32.7 million. And according to a report by World Bank, we are projected to be an aged society by 2044 with more than 14% of our population being senior citizens. With modern pressures on family increasing in juggling the rising cost of living and caring for older persons at home, the demand for long-term care facilities has increased dramatically in the last few years. Malaysia's long-term care system is fragmented owing to the divide between health and social care, as well as between public and privately funded care. Malaysia has 15 government-run residential homes and 2 government-run homes for people who are terminally ill. There are an additional 320 registered long-term care facilities, with over 1,000 facilities in Malaysia which remain unregistered. Nursing homes in Malaysia have been disproportionately affected by the COVID-19, though very much underreported with high rates of transmissions. The exact numbers of affected facilities nationwide is not publicly available, though unofficial reports have shown almost 50 plus nursing homes outbreak till date. The residents and staff in these care homes have been long sidelined in this battle with COVID-19. This crisis has therefore perversely opened up many opportunities to right many wrongs in the regulations of these care homes. With all these in mind, let us now turn to our panel of esteemed speakers to shed some light on this topic of COVID-19 and care homes. Our first panelist, Dr. Rahima Ibrahim, will be shedding light on intersectoral involvement in tackling care home issues. Dr. Rahima is an educator and researcher in Aging and Human Services. She is the Deputy Director of Malaysia Research Institute on Aging and previously the Head of Department of Human Development and Family Studies, Faculty of Human Ecology, University Putra Malaysia. As an Associate Professor at the Faculty of Human Ecology, she conducts undergraduate courses on adult development and aging, as well as postgraduate courses on social gerontology. Dr. Rahima's research interest is in the area of support for the elderly and also the relations between formal and informal care provisions for older persons. Presently, she is the project leader for the research entitled Supporting the Aged Care Sector in Preventing and Mitigating the Negative Impact of COVID-19 in Older Persons in Malaysia, which is funded by the World Health Organization. Our second esteemed speaker actually needs no further introduction. Dr. Yao Weng Kiong is the Head of Geriatric Services at the Ministry of Health Malaysia, as well as the Head of Department of Medicine at the Hospital Kuala Lumpur. He has been practicing as a geriatrician since 2000. Dr. Yao is actively involved in both teaching of undergraduates and supervision in addition to training of postgraduate candidates of MRCP, Masters and Geriatric Fellows. To date, he has been involved with training of more than 54 fellows since 2007 and has been instrumental in helping UPM, IMU and RCSI Perdana University to kickstart and run their healthcare for elderly undergraduate programs. Dr. Yao sits in various committees including Chair of the NSR for Geriatric Medicine, Private Aged Care Facilities and Regulation Committee, and is a principal investigator for dementia-related clinical studies. He was also involved in the writing of the Malaysian CPG on dementia at the first and second edition, Hypertension CPG, and is a reviewer of many other documents. He has also written many chapters on various elderly care topics. With his vast experience in this field, he will be sharing with us on mitigating COVID-19 outbreaks in care home. Next, to learn on what really is happening on the grounds, we have with us Mr. Delron Tannis Douglas, who will be sharing on home operators and COVID-19, a battle fought in unison. Mr. Delron is the current president of Association for Residential Aged Care Operators in Malaysia, or better known as AgeCOPE. Delron is impressively multilingual and he has been a strong advocate of home care operators. Prior to that, He worked for one of the largest banks in Malaysia from 1990 to 2012. Among the many job assignments in the bank, he was also an internal auditor from 1997 to 2012. Dalrin currently operates 2 licensed care centres in Kedah since he took over a charity home in 2012. During his time of running these homes, he has also been an assistant to a member of parliament for the last 3 years. Well, just before we deep dive into this exciting discussion of COVID-19 and care homes, a quick housekeeping rule. If you have any questions, please do not hesitate to type in the Q&A chat or in the chat tab on your screen, and we will facilitate to get these questions answered at the end of this session. And now, let's move on to our discussion. Prof. Rahima, over to you.
Assalamualaikum and a very good day to all who are joining us online. First of all, I would like to thank the organizing committee of the 16th National Geriatric Conference and the Malaysian Society of Geriatric Medicine for the invitation for me to share some of the insights into the involvement of different sectors in tackling the care homes issue during the COVID-19 pandemic. Hi everyone, I'm Rahima Ibrahim. I'm the Deputy Director of the Malaysian Research Institute on Aging in UPM. My presentation will contain 4 parts. The first part is I will talk about the COVID-19 pandemic and older persons in the community and in care homes. Secondly, I will talk about the aged care sector in Malaysia. The third is on the issues and challenges in intersectoral involvement, and I will conclude my presentation towards the end. Okay, a little bit of a background in terms of the pandemic and its effect on older persons. The pandemic has affected older people disproportionately, and we are looking at high number of mortality coming from those who are in the old age groups, especially those who are living in the long-term care facilities. Evidence have shown that more than 40% of COVID-19 related deaths have been linked to long-term care facilities, and in high-income countries, the figure is as high as 80%. The World Health Organization published a policy brief that highlighted key actions to prevent and manage COVID-19 across long-term care, and this is based on available evidence on the measures taken to prevent, prepare, and respond to the pandemic. Requires the cooperation and also the involvement of care providers. This is the current situation that we are in now, but the statistics recorded here is up to 31st of May, from the beginning of the situation of the pandemic in Malaysia. So started in January 2020, and we are back again in our current movement control order due to the rising number of cases. And we have seen big events that involve major clusters causing the situation of the pandemic in Malaysia. Okay, so the Sri Petaling Tabligh gathering showed an increase in the number of cases, active cases. And then during the recovery MCO, we had lower number of active cases, but the active cases have risen back again after the Sabah state elections, and since then we have had increase in the number of cases. So this is based on the presentation by Dr. Nuraliza Nordin American at the online National Forum on the Vaccination Plan for Residential Aged Care Staff and Residents. Back in February 2021. So the national mortality rate is highest among those who are in their 80s. 46% of the mortality comes from those who are aged 80 and above. And the mean age of this mortality is 64.38, and the median is 65. So we can see that people of the older age groups have higher mortality. Cumulatively, 84.95% of the mortality, national mortality, happens in among those who age 50 to 59, 60 to 69, 70 to 79, and 80 plus. The national mortality is also highest among those who have two or more comorbidities. 45.6% of those who died has chronic problems, two or more chronic morbidities. So most of those who died have chronic problems of affecting the lungs and also diabetes mellitus, and also coronary artery diseases. Yeah, so majority of those who died have these kind of chronic diseases. And the latest statistics of death by age and sex also showed that higher number of males in the older age groups have higher mortality. So now I will move on to the aged care system in Malaysia. The aged care system in Malaysia can be seen from a residential to community-based services, and also services that are catering for the independent to the more dependent older persons. So residential aged care system in Malaysia are the institution, the public aged care institution. These are the Rumah Sri Kenangan. We have 10 public funded homes in Peninsular Malaysia, 2 in Sarawak and 3 in Sabah. And other than that, we also have other state-funded Islamic homes. We have charity or welfare homes and welfare shelters. So these are spaces or institutions in which older persons live in. Yeah. On the other hand, on the opposite end, we have senior citizen clubs, health clubs, retiree and veteran associations. We have older persons activity centers. We have the neighborhood groups, the neighborhood watch groups. We have also the home health programs and also the financial assistance for the elderly. However, when we move on to the more dependent axis, we can see that most of the services are provided by private operators. Other than the private operators, we have the only 2 chronically ill homes, but these homes are providing services for people of all age groups. Similarly, under the current Act 586, nursing homes also are providing services for people of different ages. We have public and private hospitals, but these are not for long-term care, although some hospitals do have their long-term care services and facilities. We have Cheras Rehabilitational Hospitals and public and private clinics and other services for catering for the health of the elderly. But all these services are provided by the private operators. So the aged care system can be seen based on the different levels of functioning, whether it caters for those who are living independently or need some form of assistance, or fully dependent on the support provided by the staff. Okay, and the sectors providing these services can come from the government, the private, and also the charity or the non-governmental organizations. It is good to note that these institutions offers residential care. There are also those who are center-based, meaning that older people can come to the centers to have some activities or to meet up with others. And there are also services that are mobile, that are offered in the home, such as the home help, mobile nursing, and also other forms of services like Meals on Wheels and transport services. Other services include benefits for older persons, concessions if they use some form of services. They may have special lanes for the elderly, and also some non-classifiable facilities or services such as financial products, savings or bonds for older persons. So during the pandemic, there are vulnerabilities exposed because a lot of these centers or these care homes are unregistered or unlicensed. They are also experiencing lack of staff and the problem of lack of training in infection prevention and control. Issues such as closed spaces and crowded areas make it impossible for them to quarantine their residents or staff. I will share a slide later to show that these care providers or care operators are facing financial and manpower issues during the pandemic. And we know that there are studies reporting the effects of quarantine and social isolation on the mental health of the residents and also the staff. Outbreak is also happened in the care homes, but to a lesser extent compared to the stories that we hear in Europe and in US. But it does happen, and the cases are increasing lately. Some of the issues were some of the outbreaks happens when the residents transfer to or from the hospital, and during the outbreak it was a logistic nightmare for the care operators because they lacked the resources necessary to contain the outbreak, especially in terms of the personal protective equipment and to do the testing on the staff. They also lack the space for staff to compartmentalize effectively. Some of them are facing a decline in the number of staff because the healthcare workers they lose their healthcare workers to the current pandemic situation. And in terms of outbreak management, we are also facing some problems in terms of keeping track on the outbreak data. So whatever outbreak data that we found is based on the public records and also through our contacts with the geriatricians. There are also some issues in terms of vaccination. We have worked with we have collaborated with Ministry of Health, the World Health Organization, the Residential Care Association to push for vaccination in the care homes. And it is important to recognize aged care workers as frontliners because they are working to take care of the elderly, and some of them are working in multiple care settings that can pose risks to the older persons residing in the care homes. So vaccination is a way to reduce the risks of outbreaks in care homes, but there are people who still perceive that they have preconceived notions about vaccination and also other myths surrounding the treatment of COVID-19. The Ministry of Health has done, earlier on they had done line listing for the vaccination process to be done on site at the care homes. So these are some of the operational issues highlighted by the care home operators and staff. The sample contained 189 responses and the data was taken during the third wave of COVID-19 pandemic. So majority of the respondents reported that they had some cash flow or financing problem, although 48.7% said the problem was manageable. Another 30.7% said cash flow or financing was a major or very serious problem to them. Other than that, the care operators are also facing difficulty in getting grants or donations. A large number of them are facing problems in getting grants or donation during the pandemic due to the restrictions and also the current rulings during the MCO. Operators are also facing difficulty in getting payments from the clients, and there are also overdue payments that they have to get from the clients, but they are not getting it on time. The operators also reported in terms of human resource, especially in terms of high staff turnover, the lack of required training of the staff, and also difficulty in finding staff and volunteers during the pandemic. Other issues that were asked to the operators include harassment, if they have faced any harassment by local authorities. There's a small number of them, about 20% are having problems during the pandemic, especially when the line listing was done. They said that some of them probably scared to disclose about the information about their premises because they are not registered or licensed. Other issues include premise is unstable or small, also nearly 20%. Neighborhood is not supportive of their premise services, the lack of access to operational advice and support. Some of them also, almost 30% of them mentioned that it is a problem for them to meet government regulations and requirements, and they are also about 30% having problems with demands from family members and relatives, and slightly under 18% facing other issues. Okay, in supporting the aged care sector, this is a project to support the aged care sector in preventing and mitigating negative impact of COVID-19 on older persons in Malaysia. We had several project activities, including the infection control training module development and implementation on the care home staff and operators. We also did a behavioral insight survey and also the aged care industry survey, and we had phone verification of some of the addresses that we compiled, and this is to go towards the development of the National Directory of Residential Aged Care website. The implementation of the infection control training program was held in 2 sessions. In both of the sessions, we had 200 participants expressing interest, but eventually, after the briefing and during the self-directed learning, only 79 staff completed the training. There were issues and challenges in intersectoral involvement. I will summarize this in terms of the different levels, being micro system, mesosystem, exosystem, and the macro system. At the micro level or the organizational level, we are looking at operational challenges faced by the care home operators in terms of finance and also human resource to be able to collaborate on initiatives such as the infection prevention and control training, and also for the vaccination program implementation in care homes. There are also issues as isolation that were problematic for the staff and also for the residents. During our training, we found that some of the staff have had to deal with the mental health of the residents during the movement control order. The staff in general, they have a very low IPC infection prevention and control background and training. So it was a problem for them to manage the outbreak. And there are also myths surrounding the virus treatment and vaccines that is hampering the initiatives during the intersectoral collaboration. For the mesosystem or the partnership or linkages between one organization to the other, there are issues in trust, especially in negotiating disclosure to authorities. And sometimes the care operators have had to manage, they have had difficulties in managing expectations from the family, from the authorities, because sometimes these issues such as vaccination and whether like consent and issues such as whether care home is licensed or registered, these issues get bundled with the implementation of the vaccination program. And in terms of ecosystem, we have now passed 1 year of being in the pandemic. So we have seen various rulings of movement control order, and sometimes this prolonged situation is not helping the care operators in terms of their resources. In terms of the macro or the overall policy environment, there are issues in coordination because of the different authorities have to work together to mobilize their resources. But at the same time, they have to negotiate the territory because there are now different authorities which is involved in the vaccination, which is those who are involved in the rulings of the standard operating procedure. So they are it is a difficult time for the operators also to navigate the pandemic situation. In terms of communication, earlier on, there was a public announcement by the Health DG about the public training that was done in care homes. It shows the government commitment, but somehow after testing for about 500 plus homes, the communication was not done properly, and a lot of the issues were silent to such an extent that the care home operator associations or the residential care operators have to fight their way to get the vaccination plan implemented. In conclusion, the COVID-19 pandemic exposed blind spots and vulnerabilities in the aged care system, as we've seen from the previous slides. And they are, when working together with other parties or agencies, it is difficult to work effectively when there are information gaps and there are no openness in terms of data sharing between the health and the aged care sector. And the presentation also highlights issues in coordination, cooperation, and communication between the agencies when dealing with issues such as vaccination and also the outbreak management. Thank you so much for your attention.
Okay, good afternoon, everybody. I would like to thank the organizing committee for allowing me this platform to share the geriatrics committee's role and contribution in helping fight this current COVID crisis or pandemic. So I'll go immediately to my slides. I have no conflict of interest in my disclaimer. We all know by 30th of December 2019 from Wuhan, there's a virus, and within by January 30th, it became a global emergency declared by WHO, where it spread to we spread to 18 countries and had 170 deaths. And by 11 March, it's being declared as a pandemic. And in February 11, they got to know the name COVID from the coronavirus disease year 2019. And we all know this very well. Within the first week, we will have quite a few be able to get the virus positive, and it will involve many different organs in the whole body, and you have the acute and the post-acute situation. And we also know we can classify them into category 1, 2, 3 to 4 or 5, and the response will be accordingly. By Cat 3, we will start some steroids because to reduce all this whole inflammatory response, and by Cat 4, some antiviral. And by about 10 days or so, most of them will be discharged, and the virus can be positive up to 90 days. And these are some of studies that people are still looking at it, this post-acute COVID syndrome, many studies into the different aspect, different system. And we are now thinking of getting, because they have so many post-acute syndrome, in fact, respiratory, this girl mentioned that half the lungs are functioning below the, only half a lung are functioning. So that's why a few of our geriatricians are also involved in this management of this post-COVID protocols write-up, and also to help how to manage this post-acute COVID syndrome. We know hospitalization, especially in the elderly, 65 and above, 5 times more higher. And of course, death is about 90 times higher when you're 60 and 65 and above. So that's the reason why you can see many cities, including KL, become empty because of this, the severity of this disease. And our first case was in 21st January, and there was an empty period. This is a screenshot from Dato' Rohaizat's CPRC meet with all the head of service. There was 11 days, and this is his story. And that's how Malaysia approached via surveillance of public intervention, diagnostic and testing, movement control order, evidence-based approach, many guidelines of different specialty road to look into how to control the disease and prevent properly, and including protocol and training. And many of them are assessed via the HTA, Health Technology Assessment. And very important, risk communication, a transparent, factual, consistent engagement with the public, where DG have regular press conference to tell everybody about what is going on. And of course, we also isolate all the patients and treat them and meet them and manage them in the hospital and get all the equipments, ventilator, PP, all ready. So this is again another timeline which I prepared myself. We know by February, end of August, by July or so, there's only one case, by this is DG slides, 1 July, no case, no local transmission. And CNN actually says that we did very well because we have strict MCO, admit all positive case, proper contact tracing, quarantine properly, and strong leaderships of a very, our health DG. And that time, our positive rate is 0.1%. And of course, you all know by end of August or September, the Sabah election changed everything. And from then onwards, we have much more cases, and we are also almost like India currently, where our per million population is about, per million population is even higher than India. And we have 9,000 cases on 29th of May, and much more in July, about and much more. So we are no more into the usual containment, but into mitigation phase already. And so back to the topic today, as to know how we can mitigate COVID cases in outbreaks in care home. And so who are those in the care home? Why mitigate? What have we done so far and how can we do better? So who are in care homes? We know the older people, the older people, these are a very heterogeneous group. They have what we call aging process, where the healthy adult become frail and they reduce the reserve, they reach a peak and then they decline. So the reserve in kidney, all the systems in the body will decline. Physiological system will decline in an exponential way, making them vulnerable to disease and death. So the concept of hemostenosis comes in. And not only the physiological reserve, the functional, the biopsychosocial reserve also will decline. And this is the other way of looking at clinical frailty, from very fit down to terminally ill, is as a trajectory. Where as they go older, they get more frail. And it's not just physical frailty, we have to be careful because this particular person, physically, he may be vulnerable, but mentally, he's very, very fit and very, very robust. And there's a lot of what we call overlapping with disability and comorbidity. This is my mom, who is actually clinical frailty scale 5, and she refuses walking aid, although she needed. Tun M, very, very fit mentally, physically. Small minor illness, nothing will happen because she had much, much reserve at 96, 97. My mom, minor illness, for instance, a caveat, cat 1 or 2, will actually go down to this dependency state, immobile dependency, falling and delirious. So it's also in our National Health of this survey, we found that quite a lot of our elderly, 42% are functionally dependent in terms of IADL and 17 ADL. There's many syndromes. If you look at the dementia, 8.5% of the cases that translate to about 280,000 patients, and quite a lot of our nursing homes have these patients inside there, 30 to 40%, and that's going to be quite significant. Now, health delivery system, we have both the public and private. The government side, we have 144 hospitals, 43,000 plus bed, and the private 200 hospitals. The only thing is that these hospitals mostly look into the acute and the subacute. Our patients who are quite complex. This aspect of the intermediate care, long-term care, which today we are talking about the care homes, are not really in. If you look at Dr. Lee's slides many years ago, they're all interconnected except for this residential bed, this long-term care shelter at residential care, assisted living, nursing home, etc. They are all not connected in some way to the existing health system in government and public. So for that, I've been, since 2006, 15 years ago, I'm like the cat with all the dogs staring at me, presenting the problems of this long-term care to him about the law and policy, regulation, inspection, client, resident, assessment team, staff, home environment, costing, funding, etc. And what we should ideally have, full range of service, focus on caregiver, cooperation in care integrated, and so on. Like what WHO say, we should have a health system which is responsible to offer safe, accessible, affordable, and quality care, including accessibility and palliative for all people without discrimination. But sadly, that's not the case. Then we did have an act during Datuk Subra's time, but the regulation is still a problem. It's been going on for 2 years. So why we need to mitigate? We know these are the 2 homes that come on newspaper. These are the few homes that come on newspaper. Once we have COVID infection in a care setting, in a residential care setting, it'll be very difficult to control. Studies from other places, incidence rate can be 40 to 70 among residents, and among staff, 1.5 to 5.9. And the mortality rate also higher, from Israel, in Canada, compared to the community, 13 times higher, and including death, more severe the disease in Israel. So these are the places. And we know this COVID had brought disability, people with disability into the front. They have difficulty accessing food, medication, delayed getting benefit system, some experience food insecurity, and then they feel isolated. Not many have internet access, and so not easy to get this virtual replacement service. So those are the difficulty. And even then, Dato' Rahaizat, before things exploded to to what we are now, he actually talked about the potential of patient overload, more bed required, affecting hospital service, scarcity of resources, and this is actually happening to our healthcare worker, where we know the whole system is overwhelmed, and some places are like war zone. In fact, our DG have mentioned in 2019 that we are understaffed, underfunded, underpaid, overworked, overstretched, and overcrowded. So he actually been highlighting this for a while. And so in our place where this resource is very limited, especially ICU bed, we're not talking about just bed, we need all the other things linked together with it. And you seeing patients being CPR in A&E, we have to work on getting priorities where we have to use different skills like clinical frailty, prognosis, comorbidity, SOFA skills, age, others like first come, first serve, social and cognition. If the patient is foreigner, Indonesian, things like that, patient's will and family's will, So we have prioritized who gets here. In fact, this particular person in a colonel want to serve after losing leg, if it comes to most hospital, will not likely be able to get onto a ventilator machine, although he may have a chance. So this is my last patient, 80 years old, on the ventilator a few weeks ago in May, about 2 months ago. So, and now quite a few of our patients are on disposable ventilators. So what have we done so far? So that the reason why we need to mitigate the situation is quite clear to everybody now. What have we done so far? Very, very early on, last May or so, when Dr. Raizai talked about lifting the MCO, I actually highlight to him that there's many nursing homes who are actually unregistered, thousands of them, So he actually quickly talks about and I should mention about the important gatekeeping and assessment of this nursing home. And so the next day, very fast, he actually told DG, and they actually say that all residential care home, both registered and unregistered, will be screened. And the screening started in 4th May. This is done immediately, I'm so glad, Dr. Raizai, they're so proactive within 1 day, and that's it. So by July, when things died down, the whole what we call screening stop, and we also quickly write sort of an sort of guideline to all the homes what they can do in May, and of course it was edited a few times, and you can find it in the KKM's website just recently. Okay, what we wanted is to make sure we have all the recommendation and everybody follows. We also want strict implementation and source control. People come in, get gatekeeping. In fact, this China group people actually told us very, very important, before anybody come to your place, they must be clean, really, really clean, regardless of their symptoms. And of course, things like social distancing, dedication area for facility to isolate, strict hygiene, PPE, and so on. So basically to keep the COVID away from the care homes, identify infection early and prevent the spread. Of course, we are not as detailed as what happened in Taiwan, where they have a special designated chief officer responsible to prepare and to respond accordingly. And they even have a on-site planning if what happens to the homes, what they need to do, how they evacuate and shut down the place. So those are the things that we don't have. But by the 4th wave, the 3rd wave, we start planning because some homes are starting to got infected. We sit down, we look at the UK and NHS COVID decision support tool. We discuss with FMS and PKD. We get ready, tell them what we want to line list, what case to come to us. So we get them to learn CSF, get them to learn ADL, get them to learn all these comorbids and line list them so that the Cat 1 and Cat 2 get emitted to HRC, where we will manage them properly. Mind you, Klang Valley, the Selangor and KL, all the nursing home patients, all those who are elderly, quite a fair bit of them comes to the HRC, is done through a BMU, and this was presented to JKNS. And what we hope is to have a place with the appropriate leadership to lead the whole team with all the skills and the ideal environment and equipments to manage them. Like for instance, this patient in our geriatric ward, the what do you call it, the environment help us to be able to manage him in delirious patient very well without restraining him, causing problem. We also start training MOs what to do, what are the things we have to assess, what are the tools, and so on and so forth. And very important, establish ceiling of care, weighing the survival probability, again, burden of treatment, anticipation, functional deficit, and quality of life beyond ICU. So we have special forms that we discuss and then we talk. And very important, preserve health, preserve safe life, but if you can't elevate the suffering, this is what the palliation bits come in, where because not so easy, especially young people, to say the patients are elderly, cat 3, to palliate them, to say not doing anything. But very importantly, to discuss, to talk to the person and the family, the options and weighing and expectation and so on. This is what we do. But it's not so straightforward, not so easy, because we're doing it with full PP, and we're using technology, and the family are not around. And so those are the things. But yet the discussion, communication is very important. So many of our cases, sorry, this slides from Dr. Riza again. The cases, although we're supposed to Cat 1, Cat 2, but many of them are higher Cat, because no X-ray were taken. And so these patients who were go back to. Anyway, sorry, this is supposed to be a person showing this person video, and he talks to a family. Sorry, it couldn't come out very well. Anyway, our mortality in the nursing home is only about 8.6%. We have 100 plus admissions since April, and most of them in the higher clinical frailty scale. And compared to national one, which is 70 and above, 60 years old, our total is 3.5. Just now I show you one is the nursing home mortality. There's about the percentage is higher, 8.64%. So at the moment, by about July, and the other thing is this part in July we have outbreaks in 2 nursing 100 plus patients. It just overwhelmed national our HRC and also our ED. So quite a few patients were landed in ED, and the ED physician decided to send them back home. So but that point our ED have so many patients, 100 plus. There's no choice. So there was a plan that we were told to go to the home, handle them there. If they have many of them. So so few geriatrician, palliative physician, and so on went in and to assess them whether they'll be allowed to stay in there and palliate them, and those who need to be hospitalized, we try to go there. But legally, is it allowed? And also, of course, when they pass away, dead body management. So those are the things we did. And of course, very important to make sure everybody is safe. The next thing is vaccination. So this friend of mine, shows that his auntie passed away, although he had 1 dose of vaccine. So and there's a sort of a race to see COVID vaccination and COVID cases. And of course, earlier was a bit off target, but now it's getting much better. And there's many fake news. So going around, and of course, we quickly get ourselves to discuss, us, the KKM, geriatric fraternity, discuss with palliative what we can do to make sure everybody is vaccinated. In fact, we also have some issue with people claiming the unlicensed care home is a weak spot, and many are not. The problem is that some of them are demented, they cannot give consent, and of course it makes a lot of, this guy who sent a video making a lot of noise. But we got our act together and gather everybody. In fact, some of the Rumah Seri Kenangan, our geriatrician sent to assess them accordingly. And very important, positive rate, very crucial, because it actually talks about the spread of the illness. Earlier last year we only 1%, now 7%. Probably now 10%, and this 10% means there's many who are not tested positively, so that's why many cases are brought in there. So we hope, we could hope that the care homes can be, resident staff and visitor can be tested, and of course not only that, there should be a monitoring and evaluation of how efficient info channel between the two, so that with continuity and continuation of care. Future, with 1 minute more, just to quickly tell you, is there a future? Yes, it comes once every 100 years. The plague, cholera, Spanish flu, not Spanish flies, coronavirus. So we are not done yet. We have not raised a white flag. We're still working on it. The dawn is supposed to be the darkest moment, and also it can be the brightest time. I'm very happy. Many NGOs volunteered to help me, get me bed, get me walkie-talkie, get me things that I want, just like that, without even saying more. No, and I like Dr. Jamila going now telling about ventilation guideline. I go everywhere about very important. The few parties should work together in a seamless integration way. This is something which our ex-Deputy GG been forcing me to connect all these people who are helping elderly. Can we connect the dot? And I'm happy to say that we manage, and now quite a few KKs are looking into this. And hopefully we can get what we call a seamless care. And of course, recently we also work, HKL went to KPJ. So there's public-private integration can be done. And of course, our previous DG in health research also been forcing me, and being the chair of the technical working group for elderly, I actually managed to push that research to be done into this what we call nursing homes and care home. And a very important next time is big data, cloud, blockchain, and so on and so forth. So I hope it will be able to effectively. So sorry, my time is up already, but just two more last slide and say WHO part is talking about effective monitoring and evaluation and information channel. This is where the technology and big data, can be able to help in such way. So to sum up, we need to look into coordination between the various agencies and sectors. Now, at the moment, there are some silos and some argument, but like WHO say, this COVID pandemic has brought out some problems in our care homes: underfunding, lack of accountability, fragmentation, poor coordination, excuse me, and undervalue of workforce. And we know that in nursing home and the older they die more. So we have to work on this. So the future direction is probably seamless care, education, technology, policy, the regulation for the act that I have told you, NGO involvement, research. So with effort, determination, and action, we will see drastic improvement and outcome, like what happened to this minister. With that, I hope we can, like the Latin word laboramus by this Toynbee, let's work together. With that, I would like to thank everybody. So, thank you, and I'll be happy to take questions.
Salam sejahtera kepada semua hadirin. Tachia Kalai Vanakkam, and a very good and blessed day to all participants. Firstly, I would like to thank the Malaysian Society of Geriatric Medicine for organizing this E-Malaysian Congress of Geriatric Medicine 2021. Thank you for inviting our Persatuan, which is Persatuan Pengendali Jagaan Rumah Pekediaman Warga Emas Malaysia, or known as Association for Residential Aged Care Operators of Malaysia, or we are most famously known by our acronym AGECOP. We have started from the year 2016, whereby our birth was introduced by the My Aging University Putra Malaysia. We had our national delegates meeting in 2019, whereby our delegates came together and elected our president, right up to our committee members representing all the states in the country. We first came together like I said earlier, in September 2016, organized by My Aging University Putra Malaysia, and together with the Ministry of Women, Family and Community Development. Here, we move forward from 50 over operators in the first time, and then we started branches in the state of Kedah, KL and Selangor, Perak, and Penang. And we have members in every state in the country, yet we are not able to get a branch yet in these states because of the lack of quorum. AGECOP has helped one another during this time of pandemic. We have received bonds from Massimo Robert Kwok Foundation, who have given us bonds, and we help one another by giving out the bonds to every centers that were in need. We also had Meet the People, Meet the Elderly session, whereby we told them about unity. Unity is the strength of the care centers and the strength of the elderly. One of the motivation or one of the aims of AGECOP is to have more trained skilled caregivers in all our centers. We aim to achieve that by working with the relevant ministries and working with people with technology to impart technology to the elderly. Unfortunately for us, during 2020 and 2021, we were hit with this pandemic. This COVID virus that has come to our shores is like this resilient cockroach who cannot die off. Yet, we have to be resilient ourselves in our fight against this COVID that has affected our elderly the most, who has affected the elderly in our nation the most, who has succumbed the most during this time, and who have died the most. So, we age operators have come together and we realize that in order to fight COVID, in the face of COVID, we have to fight this together, a battle in unison. So it's apt that the Malaysian Geriatric has invited us to speak on this topic. Unlike any other virus, this pandemic has put us in such a way that we are in a crossroads every other week. Now, this is a pre-recorded session, and by the time this event has ended, the conflict may have took us to a different path. Things may have overtaken us. Events may have changed. Every other week we have different type of battles to fight against with this pandemic. Every other month or a few months, alternately, we still have MCOs to go through, because this pandemic doesn't seem to be wanting to go away. So what do? We have to achieve herd immunity. Now, not everyone can be vaccinated, and not all elderly in the care centers can be vaccinated. Even though some of them may opt that they want, very few have opted out. But yet again, because they can't be vaccinated, we need the general public to vaccinate as many as they can. This COVID has brought us together in different ways. We do not have face-to-face meetings anymore. We have Zoom meetings. Our children don't go to school anymore. They study at home. So much so that the playgrounds nowadays are empty. There is a sense of quietness in our playgrounds because of this COVID pandemic. The sounds of children's laughter is no longer there. And our elderly, who have never worn masks like this before, to go out, to meet people, to talk, they have to wear masks, because being easily to be infected, and they are the most weak among our population, they are the most vulnerable. Life has changed for the young people in our society too. We are not able to be together. Even family members have to sit apart. We have to maintain a social distancing. We can't be near each other. This pandemic has changed our life, as what the government used to say, a new norm. But thankfully, we care operators have come together. When the time the pandemic struck, many operators were in dire need of food. So what we did was we came together, we got big organizations like Nirvana, big companies to donate rice, to donate sanitizers, to donate biscuits to the homes that were in need. There was a short of supply of masks when the MCO was first imposed. There was not enough masks to go around to all the care operators. So what we did was we combined forces, we presented masks throughout the nation, we gave rice throughout the nation to every centers that were in need. And we distributed it throughout the country, from Kedah in the north right up to Johor in the south. And we also had companies like Inside Scoop and Appeton who donated their milk that were perishable when they couldn't produce the ice cream. So what they did was they donated their milk to all the care operators so that the elderly could have access to milk during the time of MCO. And together in the year 2020, with the Health Ministry, WHO, ourselves, the Welfare Ministry, the Malaysian Research Institute on Aging, My Aging, and the World Bank, we came up with a project 2020 to vaccinate every elderly in every care centers in the country, because this is the only fight we can do together against this pandemic. We also have behavioral insights with WHO, jointly with ISHCOP, to talk about the perspective of the aged during this time of pandemic. And we also introduce jointly with UPM and WHO an introduction course on COVID-19 infection control to train all the caregivers on how to effectively fight against COVID if there is any incidents of their centers being infected by COVID. And we knew that vaccination was a must, but vaccination was slow, and we appealed, and the Ministry of Science and Technology responded to our appeal. YB Khairi Jamaluddin brought us care operators together and asked what was our worry. And we told him that our worry was the elderly were not being vaccinated, the caregivers were not being vaccinated. YB Khairi Jamaluddin assured us that all licensed and unlicensed centers, documented or undocumented foreign workers, everyone will be vaccinated by KKM. This is how we work together. We also had help from the opposition leaders, from YB Chris of Pulau Pinang, from Penang, who helped to orchestrate the safe vaccination of elderly homes. And we had the ex-deputy minister, Hannah Yeoh, who helped to move forward the vaccination process in all the care centers. Saving the elderly and beating COVID in care centers requires joint efforts. We require the effort of everyone to work in unison, because this pandemic does not see skin color, it does not see political stand. It attacks everyone equally alike. Thankfully, thanks to YB Khairi Jamaluddin and the Ministry of Health, our centers started getting the vaccination as early as May. Many of us started getting vaccination, our caregivers started getting vaccination, and progress was moving forward so smoothly. Now, this is a pre-recorded session, and by the time this video is played, I'm hoping that by the time this video is played, all the centers nationwide, 1,700 of us, 30,000 residents would have been vaccinated successfully, and we would have probably have our herd immunity within our care operators and centers. We would like to thank the Health Ministry for the dedicated staff who, despite being short of manpower, were able to come to our assistance. And they were everywhere in every state. They were there helping us to vaccinate our staff and our elderly. We would like to thank them because they came immediately after our meeting with Khairi Jamaluddin, and they were there to help us from every nook and crannies. The Health Ministry were there for us. So, caregivers and elderly, we are intertwined. There can't be a separation of caregivers and the elderly. We are part and parcel of this together. So that's why when we ask for vaccination, we ask for both the caregivers and the elderly. Now, the setting during this lockdown, the initial stage and now too, was that due to the spread of the virus, no visitors were allowed to visit the elderly. Initially, it was from the 18th of March to the 31st of March in 2020. But after that, because of the state of the virus, the spread of the virus was so quick, we had to impose the lockdown continuously, no visitation. Now, the problem with no visitation is that the elderly were the most easily to be felt the non-visitation of their family members. They felt bored, and we had to give them activities. We had to encourage games. We had the loneliness was there. We could feel the loneliness in the part of the elderly when their children don't come, when their siblings don't come, when their grandchildren don't come and visit. So we had to take off their minds away from this loneliness. So we started doing more activities than usual to get their minds off this loneliness of being locked down in the care centers. We had colorings, we had games, we did dancing, we played music for the old people. and the senior citizens, we play ball games. We make it a daily activity so that their mind will taken off away from the loneliness of being locked down in care centers nationwide. So we make them do exercises that they normally feel reluctant to do, but because of the boredom that they encountered, we impose more games for them. We shared more things to them, and even our oldest, the oldest in my center, 97 years old, she participated in the playing of the games and taking her mind off that her children or daughter has stopped visiting her. Some of them don't understand why there is a need of this lockdown, why her children cannot visit. They don't see the risk of COVID-19. And we also got our family members to try to do video calls and Zoom. Now it's a norm to do video calls, so the elderly too can do video calls and Zoom, and they can talk to their family members via this mode of technology, whereby a few of their family members all over the country can come and Zoom with them. We just have to provide the required equipments for them to connect with their family members. And some, we use handphone, video calls from Singapore, video calls from India, video calls from overseas, so that they can connect to their loved ones who they have not seen, or even their loved ones who are in local but cannot come. We also try to connect them using technology. This was a way we overcome the loneliness the elderly felt during this time of COVID. Now, elderly people like to go outdoors. They like to lepak at the kopitiam. They do tai chi together. But because of COVID, they are like the children. The playgrounds are empty. The fields are empty today. They can't go to the kopitiam and talk to their friends or over a cup of coffee. They don't have this opportunity. And boredom comes in. They are at home. They are stuck. They can't go out. They are stuck at the care centers. They can't go out. No one can visit them. And when boredoms come, they are the first to feel depression. They are the first to feel the need of someone to talk to. But yet, they are the one most affected. They can't talk to anyone because they are stuck at home. And they don't have relatives to come and have dinner with them. Because how can someone come to visit them when you are the most easily to succumb to if we bring the virus to your home? So that's why we have to work in unison. I'm more sad for those in the villages, those elderly who has no access to internet, the B40 group, who has no laptop, no Wi-Fi. How do they cope during this time of social distancing? Can they cope? They stay in villages. They cannot afford the laptop. They cannot afford their handphone. And if they are locked down, how would they feel? Alzheimer's sets in faster. Depression sets in faster. Their mind, their brain, if they do not have activity, will slowly deteriorate. Unlike like before, they will deteriorate faster. But I would like to share, there could be a silver lining for our silver hat like citizens. All we need to do now is to reach out and support. We have to battle COVID-19 in unison together. We have to reach out to the elderly. Reach out to the care centers nearby you. Everyone can play a role. All you need is just a touch of love. A touch of love to touch the care centers, to show them that you care for the elderly there. You care for the elderly in the villages. You may not have to be there, but you could provide the technology. Some of you could provide the technology for the elderly. Some of you could provide the food that they do not have during this time of pandemic. Again, to fight against this COVID, we need to work closely with the Kementerian Kesihatan Malaysia. Without them, we would not have come this far. Without the help of Kementerian Kesihatan, Tan Sri Noor Hisham, Dr. Noor Hisham, we would not have been where we are now. We would have been far worse than we are today. So what's next? What's next for the country? Let me tell you, together we can fight COVID-19, only by being together. We can't look at political standing. We can't look at your race. We can't look at your age, because this COVID, this pandemic doesn't see all that. We need to be together as one. We need to reach out to the care centers who are unregistered, who are not licensed, because sometimes they are the one who are most in need. We need to reach out to everyone irrespective of race. We need to reach out to the retirement villages, to the nursing homes, to the normal pusat jagaan orang tua. We need to reach out to all of them because our estimate there are 30,000 elderlies in all the care centers nationwide, and there are 1.5 million elderlies nationwide. We hope our government will train more nurses to be prepared for more of this outcome, more of this to overcome this pandemic. We need more nurses because we know that without the nurses, without these frontliners, we would not be where we are today. Without these frontliners, we would be much worse than we are today. Again, this battle has to be fought in unison. We have to reach herd immunity quickly. Only then our elderly can live a life free of depression, free of loneliness. Let their final years be years of joy instead of years of depression. I would like to thank everyone for listening for this short sharing, and I would like you all to have a thought of the elderlies in the villages and in the care centers. Thank you so much.
Amazing panel of speakers. It has been very enlightening listening to all the different insights. It's a very hot topic now, care homes and older persons, and we know they have been really disproportionately affected directly and also indirectly. So let me just get the ball rolling. First question, Dr. Yao. So we did see during the first wave, I think we were able to handle the nursing home outbreaks a bit more easily, where we were able to decant the whole nursing home literally. But with rising cases and so many different nursing home affected with the bed crisis that we're having, that was becoming very difficult. Now, how do we see ourselves as the team from the healthcare as well as from the government side, preparing ourselves to, future epidemics or even pandemics? How do we prepare? There's a hot off the press in a newsletter to the Lancet. They have the 717 rule where, 7 days to detect the outbreak, 1 day to prepare, and 7 days to move on with the actions. What's your take on that? How prepared are we for future pandemics with nursing homes?
Okay, thank you very much for the question. Nursing home is a big problem. As we point out that what Mr. Darren has mentioned, registered with his is about 1,000 plus homes. The unregistered one, I think there's much more. I mean, a bit like what you talk about foreign workers, the one registered, one unregistered. There's so many of them. Now, so your question is how can we prepare? When the earlier part we've been talking about it, there's what do you call that? Klang Valley have the most homes, and there's a group where they under Greater Klang Valley they look into what to do, open up places, open up MIAF, PKRC, CAC, and so on and so forth. So every time there are meetings, I will highlight. Look here, there's a lot of nursing home, and the screening of them for the COVID status had actually stopped. So, and when they become positive, and you don't know that they are positive, as with some older people are quite atypical, they don't have symptoms. They get positive if somebody from care worker who stays outside, get positive, come in, and then infect the whole group. So we have to really look at how to holistically look at how to manage them, in the homes, because that's the environment they're quite familiar with. And of course, the moment they're positive, the usual way is to send them to a CAC, a COVID assessment center. Can you imagine Darren and all his patients? Some are demented, some are depressed, some are not mobile, sending the whole bunch of them waiting together for hours in the Malawati CAC. So one of the way we thought of is, can we go to the home, bring the mini CAC to the home, and then assess them accordingly. And those who are, very mild, stay inside and tell them how to separate them and what PPE to wear and what type of cleanliness and so infection control and so on. For that, and then of course those who needed to be sent to hospital quickly go to hospital, and of course those who about Cat 3, 4 and above who may need intervention. This is another difficult part because in my hospital in Kuala Lumpur HKL, we have so many patients and the ventilators are so limited. If you know the whole country, the ventilator is only about 1,000 plus. Recently they purchased a few hundred more but you separate it out. The ventilators are so limited. We are starting looking at priority. In my talks, I talk about the priority. How do we prioritize them using clinical frailty scale, SOFA scale, ADL, patients comorbid, patients vicious, social circumstances, and so on. And when you put all this priority, these patients from nursing home, which need to be sent to the hospital, likely if they turn bad, they will not get any big intervention. So what we thought was, why don't we get the palliative physician, to go in and manage them there in the environment where if some of them are demented, they know the caregivers in the homes. They are so familiar, and so if anything happens, if they pass away, then it's so much nicer, rather than going to a hospital, put on tubes, do all sorts of things, and very unfamiliar, frightening, and they get delirious, and people tie them up, put them on CBD, and so on and so forth. So all these things makes them very difficult. So that's what we plan, but there's some logistics because we are hospital. We can't just go to the home. There's legal aspect of it, and also when the patient died, the body management is a problem. So that was where we have a lot of discussion. We had these things was forced to me to bring up to KKM, and also I have to contact WDG, contact Perkembangan, and then the local Jabatan Perubatan JKWP got to know, and then we discussed and we brainstorm how to go about. And so, and of course, later we have to write a document ready, get a module up for the PIC, how to handle the patient, get a module up for the GP. And so when we prepare all these things, we try and get the Bahagian Kesihatan Keluarga, BPKK, KKM, the people who are involved to discuss. And well, things are moving. As I'm talking to you all now, by right, there's another meeting where I should be attending about the long-term care with the ID physician, with everybody. So basically, we are planning to make sure we manage the patients in the homes properly without them needing to come to the hospital.
Thank you, Dr. Yao.
So that's something
Definitely.
which we have to get ready. All the geriatricians, they're going to be a lot of work on top of their clinical work. They probably have to go into the homes and start assessing them. And when you go to the home, people will start calling you, this patient has this problem, that problem, and your handphone will not stop ringing. It can be a bit tough. So there's a lot of nitty-gritty we have to work on. So that's the thing that we are planning, and we are looking into how we can do better. Like Darren say, in this time is the best time, it's a crisis, and that's where we can try and improve on things. We can ask for anything, we can ask, and if it works, yeah, why not? So that's the thing, that part where sending a team to the home is something which we did. We have been going to a few when they have outbreaks, we've been going.
I totally agree, Dr. Yao. I think we have got lots of work ahead of us that we can do to work together. Next question, Prof. Rahima. You mentioned about the training module for caregivers from care homes. Do you think this would be possible to keep this going for the future?
Thank you for the question, Dr. Kija. Yes, I am in consultation with the nursing department in UM, and also the nursing association to look forward to, to try to do this training beyond the project duration. It is something that is highly needed by the care staff, and it will be most important skills that they need to know now, especially during the pandemic, and also in facing future pandemics. So yes, there is a very high possibility for the training to be continued, and I'm in discussion with the nurses in several agencies as well.
Nice. Okay, thank you. We do see lots of questions coming up, but I think due to our time constraint, we may have to wrap up. But any final words, Mr. Delrin, for our audience here? Anything in the last 10 seconds you want to say? Take-home messages?
Yeah, there are still many centers. Even today, I just received a call from Ampang. There is a center that has been overlooked in the vaccination process. I believe there are so many more out there. If any of you out there do know any care operators or centers, just ask them, call them, ask them, have they been vaccinated? And if they have not, help them to arrange with the local PKD to get them vaccinated ASAP. I was surprised in Klang Valley, Ampang, there is still centers who have not been contacted or being in touch with the PKD to be vaccinated today, this morning. So there are many out there. So I pray and hope that we can work together to save these people, to get them vaccinated first, so that the caregivers and the elderly there can be protected. And I hope everybody be safe. Still wear your face mask, face shield. Being vaccinated doesn't guarantee you have the immunity. Just be safe.
Thank you, Mr. Delrin. Any final words, Prof. Rahima, before we wrap up? I think we'll...
Okay. This is a very important time for us to get together and to work together to help the elderly, especially those in the residential care homes, and not because they are the most, not only because they are the most vulnerable, but they also most isolated from the pandemic. Aside from healthcare, they also need social and psychological interventions as well. Thank you.
Great, definitely. Thank you, Prof. Rahima and Dr. Yao. Any final words before we wrap up?
Okay, just to say that there's a lot we can do, especially this crisis bring up that that part of the underfunding, the lack of attention by the government, both the health side and of course the social ministry, and so with this we can actually push forward some researchers, intersectoral collaboration, NGO involvement, and so on and so forth. And this is the best time to also improve on the existing nursing homes, function and the SOPs and so on. And of course, there's some regulation which we are looking into it. Hopefully, it comes out soon. The regulation. There's a few questions that we need to answer. So, final word is, of course, in crisis, we still have opportunity to do something about it. Okay, thank you.
Definitely. Thank you very, very much for all of you who have tuned in to listen. And for the expert panel, thank you so much. It's been really enlightening listening to you. Thank you so much. Take care, stay safe, everyone, and stay tuned for the upcoming breakout sessions. Take care.
Bye.